Welcome to the next instalment of our Hep C Later podcast series. Today, I have the pleasure of speaking to Jade Groves, Health and Wellbeing Clinical Nurse Specialist, and Mark Prescott, Clinical Lead, who both work within the Inclusion One Recovery Buckinghamshire Service, which is part of Midlands Partnership University NHS Foundation Trust. Today, we're talking about the implementation, learning, and impact of fibroscanning within their community drug and alcohol service. Okay, so can you tell us what prompted you to start looking at doing fibroscanning within the community drug and alcohol service?
So, I know I have a little bit of a history of kind of wild ideas that are beyond what we can do. So, it was something that I know I wanted to do for quite a long time. But I think for me personally, the real driving point behind that was the length of time it takes at the moment to access fibroscans within NHS services. Routine appointments at the moment with gastro services are at least 6 months. And so we had a prime opportunity. Well, if we had this machine, we have so many opportunities where we could do that, and we could actually get that ball rolling quicker and facilitate that access quicker where it's needed. So I think that for me, that was the thing. I was just like, well, it's a no-brainer. Why don't we have access to this? Because we've got a target audience, and actually there are going to be so many people who need that fast track access that at the moment don't have any access to the scanning to even get the ball rolling.
I think as a service, actually having you in your position, Jade, as well, having somebody so passionate about driving that forward as well, it was really for the service important to harness that, I think, as well. And I think what we had prior to this was a really good pathway to hepatology through our hepatitis C service and our treatment pathway for that. So we'd established some really good pathways, and it just felt right to build upon those existing pathways to really shorten that gap that you've spoken about, that 6-month wait for such an important investigation. We had something sitting there already. Why don't we build upon that? And when I was approached, or all services were approached around the possibility of having a fibroscanner, I kind of thought it was in our wildest dreams that we would have something like this. And then when me and you spoke, Jade, we actually looked at how often could we use this, and the numbers were incredible about actually we could really, really make use of this. It would pay for itself in no time in terms of treatment, because we could fibroscan so many people. It just made perfect sense to push forward with this.
So what's the hope in terms of impact on the people that are accessing the drug treatment service?
I think the people accessing a drug and alcohol treatment service are disproportionately affected by stigma. And I think, I don't have these figures off the top of my head, so I did do a little bit of reading around it, but something like 1 in 3 people do not access medical care because of stigma, and that's particularly relevant to people with liver disease or possible liver disease. We're seeing those people. We're seeing that 1 in 3 regularly. So in terms of the impact upon our service, it's opening up something that they probably the odds are they probably wouldn't have accessed or been offered, not in a very timely manner anyway, unless it came to crisis point and things had to kick into action. We were able to do that at a far earlier stage of treatment for people. That's why, and that's the impact on the service users. That's why we're doing it. There's so many other drivers.
I think just sort of going on what Mark was saying, I think in terms of like what the hope is for me, the thing that we saw particularly during COVID and after COVID as well, the amount of first presentations we're seeing to gastro services already cirrhotic, and now we've got the opportunity, like Mark says, to get that assessment done earlier and to really, make every contact count. We've got those opportunities to say, well, do you know what, while you're here, let's just do this and let's just see where we're at. And we can now intervene much, much earlier. And so in terms of hope, my hope is that the amount of first presentations of cirrhosis is going to start going down because we've got that opportunity to get in there earlier now,
What about then sort of moving on to how it all began, really? What was the process like for implementing something like this? Where did you start?
So the first thing that we really looked at was, if we're going to start scanning, we need to make sure that we've got a process in place to deal with any results. There's no point in scanning if we can't do anything with abnormal results. So we, fortunately, as Mark said, we already had really good links with our hepatology services, with our local trust anyway. So I think that made the process a lot easier. So we then essentially looked at a process for referrals with the scans as well. So we kind of agreed on a criteria for referrals. So we agreed on a criteria of KPAs of 13 and above. And so we were then really mindful after that of, well, if we start scanning everybody straight away, there's a real potential that we could flood the hepatology services with referrals and actually make waiting lists longer, which we didn't want to do. So we looked at how we could start by sort of looking at screening the people who were most at risk first, and rather than just screening everyone straight away. So we started off by looking at clients in service with particularly high SADQ scores, and we looked at those that had any positive Hep C results as well. So we kind of did the FibroScan and their workup bloods and kind of sent everything off as a nice package for the Hep C referrals as well. So yeah, in terms of setting it up, we looked at the referral process first and foremost. We agreed on that a referral criteria, and then looked at filtering through the referral so that we're not flooding the services. As I say, we started off with our sort of high risk alcohol clients first, and then as we got to a point where we were quite comfortable that we had screened the people we really wanted screened first, we've now sort of started to introduce that as a routine part of an assessment for a health and wellbeing assessment and for an alcohol detox assessment as well as it being a routine part of the referral for Hep C treatment as well. We kind of do everything all in one package. So that's kind of how we looked at setting it up. We've got obviously we've got Wickham and Aylesbury sites as well. So we've looked at how we can make sure that we're creating sort of equal opportunities for scanning on both sites. So the detox nurses set up a rota for the scanner to go across both sites as well, with what I refer to as mop-up clinics, so that if anybody in the other service we want to scan, but the scanner's in the other site, we've then got opportunities to book them into the mop-up clinic so that we're not missing them and saying, oh, well, we haven't got the scanner today, we can't do it. We're then booking them into a specific clinic.
Can I ask, do you have any idea at the moment how many people have had a FibroScan and how many referrals you've made from, since the start, and what date it started to,
Yeah. So I've pulled off a little bit of some figures this morning, but I think one of the things that I probably want to look at actually as a kind of an outcome from this is looking at how we're recording the referrals, because I know there's been more referrals than this, but I think perhaps on ILI we're only ticking the hepatology referral box when it's a Hep C referral, not necessarily when it's an alcohol referral. So that's something that I would like to have a look into. But to date, so far, we've done 84 scans. And from what I can see, obviously, we've got a number on ILI of Hep C referrals in that time, but going back through case notes and things as well, it looks like around about 20% of those scans have resulted in referrals. And we have had a couple that we have picked up as cirrhotic that were not known prior to that.
And were they people who were cirrhotic without a Hep C infection?
Without.
So that's really. So there were people that otherwise that may not have been picked up at all.
No.
Wow. Yeah.
No. So that's really been quite significant. And there was a case study actually that I used a little while back for a presentation that we did for our commissioners, where there was actually one that was picked up as a suspected malignancy. So yes, there was a case study that we used for our commissioners that was somebody that we saw and screened. She was on the waiting list for a routine assessment with gastro anyway. But in the interim, we saw her and we scanned her to kind of speed up the process if it was necessary. So she, as a result, she was moved from the routine list to the urgent list, and she was seen, I worked it out, and she was seen about 14 weeks sooner than she would have been on the waiting list. And then she was referred for further investigations due to a suspected malignancy. In that case, fortunately, it wasn't. But for me, it was an example of how, you know, we potentially could have picked up on something there that wouldn't have been picked up on, especially if it was a malignancy and her having to wait longer, you know, 14 weeks, you know, it takes about 16 weeks for a tumour of that type to double in size, you know. So yeah, so that was a good example that I just picked up on. But as I say, in terms of the amount of number of scans we've done, the number of recorded scans on Illy at the moment is 84.
But you're saying that you think that the number is much higher. It's just about getting a system in place.
Yes, I do want to have a look into it, and I do want to have a look into how we can record the hepatology referrals, but also how we can differentiate, was it a hep C referral or was it an alcohol referral? Because I think that's actually quite important, because I think otherwise we're not really reflecting that data. We know we're doing it, but we don't have the numbers to show.
That would be really rich to show commissioners, wouldn't it, as well?
And what about then, what do you think the impact is on hepatology itself? Have you had any feedback from them?
Yes.
I think you had a really good quote from Dr. Mags, didn't you?
I did. I got a quote from him for another presentation that I was doing. And I think one of the things that's been really good as well is you know, I'm really quite proud of the relationship that we have with the gastro teams, you know, and what's really good now is if we do have somebody that we're both working with, quite often I'll get an email from, you know, James Mags to say, we've got a referral for this person, are you seeing them, can you scan them and let me know if I need to see them sooner? And, you know, so that's really, really helpful, because as I say, you know, the main impact there is that we're reducing those waiting times. And identifying the people that do need to be seen sooner, which is great.
And I think you've done a lot, Jade, in making that relationship with hepatology more sustainable as well, because always it was Dr. Mags that we worked with, and it was really reliant on having a really good link with an individual, but there's so much more that you've established with the wider gastro team there as well, which really strengthens the whole pathway, doesn't it? It really lends itself.
Yeah. I think we've got the whole team really. They've come into our service as well, and spent time with us, and you know, come and spent time with me in clinic and things as well, just so that we can really see how each other's working and how we can really make it work really smoothly for clients. So yeah, we've been really lucky, I think. You know, yes, I think we've done some really good work, but equally I think we have been really lucky with the teams that we've got.
Absolutely, yeah. There feels like a real will in some areas for different parts of ICBs and healthcare providers to work together, and this seems to be an area in Bucks that is really developing well. There seems to be a co-produced kind of idea of what we want in Bucks. And I think extending that further, I suppose, is thinking about, and I don't know if you were going to talk to it, Jade, or not, but we were approached by a local GP who had funding to do the sort of early cancer detection kind of thing, part of core 20+5, to identify liver cancers earlier. They knew nothing about what we were doing with fibroscanning, and when I spoke about it, and hepatology were also part of the project, the GPs were so impressed, and it feels like it's linking into other real key priorities of the healthcare agenda, the core 20+5. We are really part of that, because we can clearly identify that for that part of the +5, we are really lending something to the project that's going on, that's really tangible as well. We can really feed into that.
And part of that work as well is we've actually had one of the members of staff from one of the surgeries actually come in and spend time with us in clinic, just to look at how we do the scans, how we facilitate the clinics and everything, to then be able to take that back and again just improve access to scanning in other areas as well. So we've kind of supported their setup as well, which has been really good.
So I think what's quite notable about that is obviously you've got the, I suppose the obvious benefit, which is the benefit to people accessing drug treatment services. You've got all the health inequality work that you're doing, but you've got almost this skill swap as well going on, where you're allowing other professionals from other areas of healthcare to see what is actually happening in drug treatment services, which again is really important for all the work around tackling stigma, all the work, future collaborations that are going to be really meaningful, and widening that work, and I suppose showing as well what drug services can actually do, the skill set that is there, because it's a very a very good skill set that practitioners in drug services have. So what about sharing the learning then? Where have you shared this learning so far?
So we did a presentation a little while back for our commissioners to look at, the scanning and what we've been doing and what we had found from it, and the challenges as well. At the time, one of the main challenges that we had was the demand for scans, in that, we know that in Bucks particularly, there's more people needing scans than there are scan appointments available, but also for us it was the access to an XL probe at the time, and that was really limiting the amount of scans that we could do, because a lot of our service users, their livers are slightly deeper, and actually it meant that we couldn't scan them. But now that we've got that, we've seen that we're doing more and more scans, which is great. So we talked about the challenges and things like that, and the learning that we'd got from that, and that's where I used things like the case study, and looked at how many referrals we had done. Also, we linked it in with things like obviously the Hep C treatment planning, the results that we had from scanning in terms of abstinence as well. So kind of using those scans, especially with the livers that we've now got, using the scans and providing that education to clients to say, okay, this is what your liver is looking like at the moment, this is what it should look like, and having that real sort of representation, and those real figures, for some people worked really, really well. And actually we did achieve, we had quite a few people following their scans that did achieve abstinence, which has been fantastic as well. And it's also something that we've linked into the green agenda as well, which I wasn't really sure how we would be able to do that at the start, but we're looking into things like how far people have travelled for their scan, and actually how far they would have to travel to go to their local trust or anywhere else that's doing it. But yeah, that was one of the areas that we had shared the learning that we had from that as well. And then obviously the Aylesbury PCN liver project as well, the Detecting Liver Cancer Earlier project as well. And then I think more locally, in terms of inclusion, one of the things, the opportunities that we had from Bucks was to support Hampshire in the setup of their clinics as well. So that was where I then had an opportunity to share the learning that we had. And it was more sort of practical learning as well, of actually, this is the best position to get a good angle, and this is, and things like that, making sure that you've got the setup correct, and looking at how to set up the clinics, and where you can actually implement those scans and where you can fit them in. So so that was a really good thing for us to be able to share the learning internally as well, and then obviously enhance the services that we're offering.
And I think there's wider application of that learning as well from what I see. I think because we have developed, obviously it's continuing to develop, but so far it's been really successful working with hepatology. The learning from that can be applied to all areas of what we do, and linking into areas of healthcare that have traditionally been harder to access. We've got something working well, and we can apply that knowledge and that learning to those areas. So whilst it may not be sharing that learning at the moment, internally it's shared and it's understood, and it is being applied in areas. So it's opened up doors for me to talk to like the health inequalities lead in the ICB, which has led to service users being able to feed back on the new primary care strategy in Buckinghamshire. It's all come from it. It's not in isolation. It's all because we've done something in partnership with a really important area of healthcare that's raised the profile. It's raised the knowledge of one recovery bucks and drug and alcohol services, to know that actually we can be really effective in developing healthcare for people locally. So it's opened avenues, like I say, I think, and it's no coincidence that we've got this pathway working really well, and then these other avenues have opened up.
So a real opportunity for drug services to showcase the skill set, what's possible, you know, and really deliver all the positive outcomes that we really want, you know, that people aren't getting because of, you know, barriers in access and all those sorts of things.
Like Jade says, we've got professionals wanting to come and spend time in the service to learn what we do, because if you didn't hear about it, you would hear drug and alcohol services and be very limited in your understanding of what actually happens behind the doors of a drug and alcohol service. With so much more, inclusion is so much more. We really try and reach out into all these areas where people accessing our service haven't been able to reach before.
So obviously, hepatitis C microelimination is happening across the country. I know that the NHS Addiction Provider Alliance has achieved microelimination in around 20 drug and alcohol services. So the focus in those services which have achieved that then becomes about sort of widening the work, reaching as many people as possible, and looking at other health and wellbeing interventions that support that. What would your advice be to other drug and alcohol services that are thinking of implementing something like this?
I think my advice would be that the key in all of it is going to be the working relationships and the networks that they have with their hepatology and gastro services. That's really going to be the first port of call. Really is going to be to really develop those working relationships, because without them you can start doing scanning and things, but as I said earlier, you know, if you've got abnormal results and no process to do anything with them, then we're kind of doing a disservice to those clients, you know. So I think my advice would be to really develop those pathways first.
Yeah, those partnership links need to be really developed. Listen to your service users for sure, making sure that you build the service user voice into this. So the Hep C pathway years ago developed because we were getting such strong feedback from service users that it was inaccessible, that it was too fragmented to try and access services. So you need to listen to your service users, develop those partnership links, make sure you take every opportunity to integrate into ICBs where you can. We've had the fortunate position of having somebody like a consultant who's very good at telling us about people to connect with. But if you can make those connections, it's really essential. It opens up conversations much more successfully to start developing things like this.
Yeah. And what's the feedback been from the people accessing the drug services that have a FibroScan? What have they said about all of this?
I think the main feedback that I get is surprise when I say, that's fine, like we can do the scan while you're here, and they say, you know, I didn't know you could do that. So I get a lot of surprise, pleasant surprise. But I think one of the sort of the main feedback is that it's so much easier having everything done in one, you know, coming in for an assessment, especially things like the health and wellbeing, coming in and having kind of a full health check all in one, has been well received, I think. actually, yeah, if where we found previously where, you know, perhaps I've done an assessment or my colleagues done an assessment and then we've referred on for further assessments, what we've found is that perhaps those further appointments then haven't been attended, whereas when it's all done in one, then it's much more desirable, and from what I've experienced, service users are much more likely to engage in it.
I think working in our types of service, drug and alcohol services, the effectiveness of opportunistic interventions, making every contact count, is so valuable. It's when you have planned interventions with people who may have lives with lots of challenges and very changeable elements, committing to appointments and things like that can be very difficult, particularly if you make an appointment in 8 weeks' time or something like that. If you have somebody in front of you, we know we're good at this stuff. We work in drug and alcohol service. We know we've got a moment with this person and we can take that opportunity to see them, to do an effective piece of health intervention with them that otherwise they may not have ever accessed. I think we can apply that to all areas of what we do in drug and alcohol services, but this is another area. Like you say, Jade, people are like, wow, I didn't know you could do this. Yeah, we can, and we're going to, if you give us your consent, we can do this right now.
Yeah.
And I think there's value in drug and alcohol services being able to do this because we are not afraid of doing opportunistic work like that.
Absolutely. I think what I've seen in the last few weeks particularly is that we're now at a point where some of our service users do have an awareness that we can do the fibre scanning and that we do quite sort of enhanced assessments, and we're now at a point where we are having some service users that will come in and request to have those assessments done because they want that reassurance. You know, perhaps they're abstinent now and they want that reassurance that, you know, their liver is recovering or that they haven't done any permanent damage. And, you know, in cases like that, it's so nice where you can then do that scan and say, look, this is where you're at. Actually, there are no signs of any permanent damage, and, you know, it seems to work really well. And like I said earlier, being able to have those figures and give that real visual of what's going on for their liver health has been really impactful for their recovery in general.
So obviously, Inclusion Buckinghamshire have micro-eliminated hepatitis C. You've also now got the implementation of the fibre scanning well underway. And I know that you have a really good offer around health and wellbeing. So what is next for Inclusion Buckinghamshire in terms of health inequalities work?
Jade, I think you've got something exciting, haven't you, being worked on?
Well, yeah, I've got a few things I'm working on at the moment. One of the things that I found out in the last few days, actually, we've finally got approval for and will be delivered very shortly is spirometry. So we've linked up with the specialist respiratory nurses within the ICB, and part of the assessments that we will be offering now is respiratory assessments, including spirometry. So I'm really excited that our machines will be delivered really soon. We've been after them for about a year now. It's been lots of paperwork, so yeah, it's really exciting that that's now happening. And there's a few, Mark, I'm not sure which one you're referring to. I've got so many different things.
Well, I think
working on at the moment.
I know you always do, Jade. The one that I really am really excited about is the health literacy project that you will be doing.
Yes.
Because I think that's going to add so much to what we do and to really help people to understand health.
Yeah.
Conditions, the importance of engaging in certain healthcare interventions, and to change that, because we do so much to people, and to really make it effective, if those engaging in our service can really understand why they're having those things done, really understand why those interventions are going to be so much more
It's so
effective.
huge, isn't it?
Huge.
When I was doing some research around sort of health literacy and health communication, sort of in the work up to looking at this project, you know, there's research that suggests that about 60% of people that access health services don't understand the information that they're provided with. So it kind of prompted us to have a little look into, well, what does our health communication look like? You know, are we using different platforms? So how are we communicating those messages? You know, and what do people prefer? How do people prefer to receive information? And, you know, so we wanted to look at the information that we're giving out already, how it's received, how service users would prefer to receive that, and then looking at where we can adapt those messages to suit everyone. But also I wanted to look into things like, you know, how many or sort of what percentage of our service users, you know, have perhaps neurodivergent kind of diagnoses, or, you know, how many of our service users are registered blind or deaf, or both, or, you know, and actually are we adapting things where we need to. So there's lots of things that we'll be looking into, and how we can adapt messages, and then obviously the purpose then will be to go back and reassess how well that message is then understood once any necessary adaptations are made.
Yeah.
I think that's really important, isn't it, around like helping people to navigate the healthcare system, as we as healthcare professionals struggle to navigate the healthcare system and understand, you know, the literature, what's expected of us. You know, if we can do a little bit more for people accessing our services, I think that is a very, very valuable piece of work that's probably quite underrated.
Yeah. I think a more, and what you're speaking to there, Deanne, really, really encapsulates the links with mental health services. I think where services are really complex, and yet, like you say rightly, as a professional, sometimes that's really hard to try and get to the right place. And you're somebody who has all the infrastructure around you to be able to do that. I think one of the priorities for me as clinical lead, so last year we launched our new joint working pathway with mental health services, and I think really addressing severe mental illness, you know, co-occurring conditions together is a real priority, and it's an ongoing thing, and it never quite feels that we've got to where we need to be to deliver the right services for people. I think we've seen some really good initiatives like mental health wellbeing practitioners coming into drug and alcohol services. I think that's a really good addition, a really effective addition to help start bridge that gap. And we're starting to see some really effective referrals to the talking therapy service locally, for example. And I think, again, that's been really helped and aided by having our own internal mental health wellbeing practitioner. But yeah, that is an ongoing priority, I think. And I think there's no better example of a health inequality, I think, than somebody who has a substance use issue and needs to address a co-occurring mental health condition as well. It's so challenging, and that needs to be a priority for everyone, I think, to really build those pathways. We are lucky we've got a service locally who is very much engaged in that, but yeah, it's made up of so many different departments, the mental health service, and different service provisions, so there's a lot more people and teams to try and engage. But I am applying the learning from the hepatology example to try and lift what we can from that and apply it to that. I think it's just a more complex area to build.
And is there anything else you'd like to add around Fibroscans, or anything around the rest of the work that you're doing?
I think I would just add that I think Fibroscans are absolutely fantastic, and I'm so pleased that we've got them now. I think that's all I would add, is I think they are amazing, and they have just opened up so much more access.
And from my perspective, not necessarily on Fibroscans, but as part of addressing health inequalities as a whole, again, inclusion, we've implemented Bufidil this in the past year. And I think that is also going some way to address health inequalities as well. And it opens up time for people to access necessary health interventions. It takes some of that complication away from people who may have many commitments they need to attend to. Drug and alcohol is not their be all and end all. It's not the only thing that defines them at all. They've got lots of other things. They may have health conditions that need other appointments, and having something like Buvidal can lend that extra flexibility to people, and that goes some way to address health inequalities. All of these little things are combined to be a really powerful, effective change.
Fabulous. Okay, well, thank you, Jade Groves and Mark Prescott, for sharing all of your insights and learning with us today. If you would like to know more, you can get in touch with Hep See You Later by emailing us at connect.hepseeyouLater@mpft.nhs.uk. Or if you want to watch more videos, podcasts, and access our resources, you can visit our website, hepseeyouLater.com.